Okay, thank you all. I want to introduce the team that are presenting. This, by the way, is not a research study. It's a program, evidence and learning generation, focus for climate adaptation. And we're looking at strengthening Somalia's system to cope with extreme heat in this particular context. I will just do a very brief introduction and pass over to my colleague who's sitting in Mogadishu to walk you through the results, the approach and results. International Medical Corps, we're the implementer. We're working on this program with funding from Novo Nordisk and in full collaboration with Somali Ministry of Health and obviously a lot of local partner inputs. We not only work in Somalia, we've worked across 85 countries over the last 4 decades, essentially. And our programs are largely in humanitarian contexts, moving through relief to recovery, and address a wide range of health and social determinants. So we're looking at, as you can see, a broad spectrum of sectors with a very multidisciplinary approach on the ground. So with that, climate is integrated into our programs. As it happens, this is a standalone program that is testing and learning, as I said. I will now relay to Hassan, who will take you through the story. Thank you.
Thank you, Anne, and thanks for the introduction. My name is Hassan Moujasi, Climate Change Officer in Somalia. Somalia is one of the most vulnerable countries to climate change. Due to this, now its temperature is projected to rise from 1.5 degrees Celsius to 3.5 degrees Celsius by 2040. Due to these extreme heat waves, currently there is 3.8 million people internally displaced due to these extreme heat waves, mostly people at risk. There is also an increase to 7 to 20% mortality during the heat waves compared to other normal days. In Somalia, there is overall underlying lack of investment and resources to advance Somalia health resilience system. Next slide, please. Due to this one, and to reduce the heat-related morbidity and mortality in Somalia, International Medical Corps is implementing multiple programs in multiple regions within Somalia to enhance and strengthen Somalia health resilience system. This project is funded by Novo Nordisk Foundation, which we are highly appreciated. It is implemented in 4 districts in 4 regions of Somalia, mainly Baidawa, Johar, Mogadishu, and Galkay. The focus of this project is mostly innovation and learning. And why is it innovation and learning? Because it is one of its first kind of project, specifically focusing on heat and health impact on most vulnerable communities in Somalia. Such a program has not been done before. So this program focuses multiple objectives. One of it is to conduct heat health vulnerability capacity assessment, prepare heat health action plan, capacity building for health staff and for district health management team, as well as community health workers, and also provide key heat health related messaging for the communities. When it comes to the heat health vulnerability capacity assessment, our main scope of this project was 474 household surveys have been done, 17 health facilities have been assessed. We have done 28 key format interviews and 8 focal group discussions. Why have we done this one? To capture institutional and community perspectives. We have also reviewed secondary data, including district health routine informations. Next slide, please. key summary or key findings from this vulnerability capacity assessment includes as the extreme heat gets more intense and widespread, we have found out that internally displaced people are exposed twice compared to other non-displaced communities. And this one is also compounded further at the household levels. Heat health impact is increasing and getting worse, hitting women and children hardest. It has also been found that it is exacerbated by the increase of non-communicable disease, where areas of health facilities capacities are mostly limited. In terms of adaptive capacity, we have found that it is very insufficient. In our assessment, we have found that health facilities possess fewer than a third of core capacities to protect from heat. Heat remains a surveillance blind spot compared to other climatic shocks such as flood and drought issues. We have found also there is room for improvement needed in terms of national heat health related policies. Next slide, please. From this presentation, I will walk you through on key recommendations that we found, especially at the shaded green areas. For the pink shaded areas are future priority investment required in terms to enhance the Somali health resilience system. At the community level, we are improving awareness and behavior change. At the health system level, IMC is expanding cardiovascular disease services such as screening, medication supply, and buffer stocks. We are also standardizing on protocols and cascading training. At policy and institutional level, IMC is enhancing intersectoral coordinations. We are also strengthening heat health-related action planning. Next slide, please. Now we will take you through how we are working on this recommendation. In terms of the recommendations, what IMC is doing is heat and health management preparedness and action plan for district facility level based heat action plan. We have done this one in partnership with the Minister of Health in Somalia. We have done through this one by holding different workshops for the districts, for the 4 districts as mentioned, such as Jar, Kalkayo, Maidawa, and Mogadishu. Each district conducting 2 days workshop by inviting different stakeholders, both the government, the civil society organizations, academia, to provide their perspective and input. One of the key results and success that came from this heat health action plan is strong government buy-in, since it was government-led, supported by IMC. We have also improved community awareness. We are linking heat plan to broader disaster management approach so that it's fully integrated to other existing policies. Forward for future areas of investment in this one is to mobilize ministry ownership of plans and integrate this one into existing national adaptation plans, as well as the national determinant contributions. Next slide, please. We have also conducted training. This training included for both virtual and also in person. The type of training we conducted is impact of heat on health for clinicians, impact of heat on health and heat health messaging for community health workers, and cardiovascular disease case management for clinicians. Through this training, we have reached 119 individuals. The successes based on the post-test evaluations that we carried out training were well received, understood, and a high level of engagement was done. Health staffs who have been trained are now using the heat health tools and guidance in practice. Challenges included climate is a new and complex for many. low literacy among the levels of community health workers. There was also limited access to localized heat health-related illness data. Next slide, please. For the capacity building priority for future investment, we are continuing to follow up on supervisions, mentorship, and refresher training. We are continuing to cascade and scale up collaboration with local and national government by building on existing Ministry of Health led pre and in-service training to incorporate health diagnosis and management into national curriculum. Next slide, please. Risk communication and community engagement for climate, heat, and health. Remember now, messaging is very important and awareness raising. International medical corps and IAMS and community health workers have designed key heat health related messages by adopting existing content from World Health Organization and International Medical Corps messaging banks. These messages were then shared with the Minister of Health for review and approval. Channels used to deliver these messages include both door-to-door, radio, community gathering, and at IMC supported waiting health facilities. Successes include high message retention, materials were considered useful and appropriate, community trust increased over time, CHWs learned along with community. Through this one, we have reached around 69,686 individuals. The challenges we face include perceptions of origin. Some people believe that climate change is God's issues and not to do anything with human. There are also competing priorities where communities needed, instead of messaging or awareness, they needed some materials to be provided them. Next slide, please. Priorities for future investment include impact climate messaging into existing IMC projects, employ diverse and interactive methods to enhance public awareness and change negative strategies, integrate climate and health messaging into national community health strategies, and leverage stakeholders to push this forward. Next slide, please. How are we elevating heat health policy agenda? We have conducted high multi-stakeholder meeting led by the federal government ministries to advocate heat health policy integration. This was presented at COP30 preparatory workshops. Now, the success includes Somalia's COP30 delegation used the findings from the BCA and recommendations to advocate for climate action in Somalia. There is also a limited understanding of the nexus between climate change and heat health impact. Next slide, please. Policy priorities for investment. We are sharing approaches and program results and learning outcomes to national and international platforms such as COP30 and coming COP31, integrating climate health RCC into national community and health strategy. We are continuing to advocate for climate and health policy integration, both state and at federal level and global level. Next slide, please. Handing over to Anne to conclude for us.
Okay, that was a very quick lightning speed walk through what the various areas of the intervention are and the learnings and priorities for investment. Just to say that this is informed by the WHO climate, the health system climate resilience framework, which is targeted for low and middle income countries. Needless to add, as you could see, the challenges are great in such contexts. In context of fragility, we have obviously gaps with governance, policy, capacities across that spectrum that we're looking at, institutional level, health system, frontline, health workforce capacities, and so on. So we want to make sure that what resonates here, I'm sure with all of you, is that capacities need this continuous strengthening. Learning needs to be continuous and adaptive, and ultimately the priorities remain for further investment to really get these types of programs to scale. Thank you very much.